Okay. Good morning, everyone. I'll be presenting about little beans. Coming to the case scenario, Mrs. Yum, a 47-year-old lady with gestational age of G4, P1, live L0, death 1 and abortion 2, presented to us at 24 weeks plus 6 days, conceived after IVF third try, came for regular checkup for diabetes mellitus and hypertension. Her last menstrual period was September 10. Her presenting complaints are she didn't have any headache, no abdominal pain, no flank pain, no vomiting, no loose stools, no dysuria, no hematuria, no history of fever, no oral ulcer, rash, or other skin lesions, no use of over-the-counter medications for pain. Coming to the past history, she is a known case of diabetes mellitus for 8 years on insulin Act Rapid and Glargine 8 units in the night. She's a known hypothyroid for 6 months on Eltroxin 87.5 microgram. She's a known hypertensive for 2 years on Labetalol 200 mg and Nifedipine 10 mg twice daily dose. So patient has undergone treatment for secondary fertility and after 3 attempts of IVF, she has conceived. No history of preeclampsia in the previous pregnancy. Coming to the examination, her vitals were BP was on the higher range 160/70, respiratory rate was normal, temperature she was afebrile, heart rate was 92. JVP on general examination, JVP was not elevated. She is afebrile and well hydrated. She is conscious and cooperative. So coming to the cardiovascular system, S1 first ultrasound and second ultrasound. Okay. It's not coming. Coming to the systemic examination, cardiovascular system, first ultrasound and second ultrasound heard normally, no murmurs were heard. Respiratory system is normal vesicular blood sounds heard bilaterally, no adventitious sounds. Perabdomen soft, distended, non-tender, no organomegaly. Uterus was felt in the range of 24 weeks of gestation, that is near the umbilicus. Central nervous system examination, higher mental functions were normal, no obvious neurological deficits were noted. So coming to the investigations, her hemoglobin was 7.2, MCV of 83.7, total count was 13,700, differential count of neutrophil was 74, lymphocyte was 20, platelet was 2,31,000, sodium was 134, potassium in the higher range 5.6, bicarbonate was low 16, creatinine was 1.72, urea was 40, urine analysis we did showed proteinuria, 24-hour protein showed 540. HbA1c was 5.8. USG abdomen showed kidneys normal size, only right renal cortical cyst were present. So what are the differentials we considered at this point?
Okay. Can you just give us a summary of your case, Brightlin?
Yes. 47-year-old gravida and G4, P1, L0, D1 and abortion 2 presented to us with 24 weeks plus 6 days of gestation. Further regular follow-up for diabetes mellitus and hypertension. She conceived after 3 tries of IVF. Investigations wise showed low hemoglobin, that is anemia with elevated creatinine, and proteinuria with the electrolytemia and low bicarbonate level. We have three response: AK, HELP syndrome, and RTA. So the differentials we considered was preeclampsia in chronic hypertension, chronic kidney disease in pregnancy. So our patient was evaluated outside and found to have FSGS due to hypertensive retinopathy, and it's not preeclampsia causing the AKI. So I'm going to present about how to approach to kidney disease in pregnancy. So out of all the pregnant women, 3% have underlying CKD, but it is usually mild to moderate. In normal classification, we use for this chronic kidney disease stage 1 in the range of creatinine clearance, stage 2 until stage 5. It's not actually useful in the pregnancy. That's because of the physiological changes in pregnancy. So coming to the physiological changes, so during pregnancy, kidneys go pronounced hemodynamic, tubular, and endocrine changes. So out of this, we can see this. This is the box showing the physiological changes in pregnancy. The increased, here we can see which all and which are all decreased. Total blood volume is increased and cardiac output is also increased. So level of nitric oxide and relaxin increased, and there is a relative resistance to the vasoconstrictor. GFR increases by 50% as well as the urine protein excretion. So GFR, with the GFR and proteinuria, we can't differentiate whether it's a kidney disease in pregnancy. What decreased are the systemic vascular resistance, blood pressure, and creatinine. Here we can see the increased parameters. Here this graph showing the as the gestation increase, there is an increase in the renal plasma flow as well as the glomerular filtration rate. This red line showing the increase in the glomerular filtration rate. It is max in the range of 18 to 20 weeks of pregnancy, as well as the effective plasma renal flow is max in the range of 26 to 28 weeks of pregnancy. So coming to the proteinuria part, so normally we consider proteinuria in pregnancy only if there is above 300 milligram per 24 hours, because in pregnancy the protein excretion is elevated, probably because of the effective renal plasma flow is increased and there is hyperfiltration and there is change in the permeability in the glomerulus causing the increased. This graph showing the increased albumin excretion that is normal during pregnancy. It's max during the 24 and 28 weeks of gestation. So here this table shows the mean changes that happens during pregnancy. Here we can see that effective renal plasma before is 480, normal is 450 to 700. In the first trimester, it increases to 850. In the second trimester, it increases almost to 900. The third trimester, it increases to 750. GFR, here we can see that normal is 100 to 120. Here it is increased till 160, 170, and 165 during the 3 trimesters of gestation. Serum creatinine, as you can see here, because the creatinine, the GFR is increased, there is a fall in the creatinine. So in the first trimester, there is a fall in creatinine to almost 60 if the patient has a creatinine of 7.3, 0.73. And also in second trimester, it further falls even more. And third trimester, it is again 64. Urea also, there is a fall. And osmolality also, there is a fall. So what happens in CKD is the patient with already the problems in the nephron, the physiological changes, they are not able to cope up because of the problems in the kidney. So they are not able to adapt to the increased renal plasma flow, so of renal function. So coming to the complications of CKD in pregnancy, what all to watch for if the patient presents to us with chronic kidney disease. One thing is superimposed preeclampsia, CKD progression, dialysis in pregnancy, anemia of chronic disease, venous thromboembolism, and volume overload. The main thing is the superimposed preeclampsia, because both the people will have elevated creatinine and proteinuria. It's hard to differentiate between the preeclampsia as well as the CKD part. So coming to the preeclampsia, so preeclampsia is higher in all stages of CKD compared to women without CKD. Here we can see that normally in preeclampsia without chronic kidney disease, almost 94% stage 6.5% of women has stage 1 disease with almost 94% recovery. Whereas in chronic kidney disease, there is superimposed preeclampsia, there is worsening of CKD that will happen. So here we can see that around 20% of women who developed early preeclampsia, that is less than 30 weeks of gestation, with heavy proteinuria have previously unrecognized chronic kidney disease. So fetal, why this preeclampsia and chronic kidney disease is a problem is it severely affects the fetus growth, thereby resulting in intrauterine death, severe IUGR. So these things has to be identified early and promptly treated with. So when to suspect preeclampsia in CKD? Patient previously with CKD most likely will have hypertension. If the patient has preeclampsia, there will be a new onset hypertension even with the regular medication she is taking, even if the BP is more than 140 and diastolic BP of 90, or the patient develops maternal organ dysfunction after 20 weeks of gestation, and there is sustained hypertension even with the medications that are used, and there is doubling of antihypertensive agents if doubling of antihypertensive agents occurred during pregnancy, which was with the BP which was previously controlled with the usual medication. Then there is an increase in proteinuria compared to the previous thing. So one another thing we can use is angiogenic markers, this placental growth factor and SFLT1, soluble FMS like tyrosine kinase. These factors also can be used to differentiate between preeclampsia and CKD. It will be elevated in preeclampsia and it will be normal in CKD. So this maternal organ dysfunction, what are all these considered as maternal organ dysfunction in pregnancy is acute kidney injury. The patient has stable creatinine value of 1.7. Suddenly the patient develops creatinine value of 2.2. It increases within 1 to 2 weeks time. Then that is considered a maternal organ dysfunction, or there is liver involvement as if in HELP syndrome presenting with hemolysis, elevated liver enzymes and low platelets. Neurological complication, patient develops seizures, altered mental status, blindness, stroke, severe headache, and visual scotoma. Hematological complications, the patient develops DIC and HELP syndrome, platelet count, and hemolysis. Or the patient develops uteroplacental dysfunction in the form of IUGR, an abnormal umbilical artery Doppler, or stillbirth. In all these patients, preeclampsia superimposed to the chronic kidney disease should be suspected. So one other thing is low dose aspirin is used in the prevention of preeclampsia in high-risk groups. The high-risk group included are family history of hypertensive disorders, chronic medical disease, or there is a pre-exist, that is chronic hypertension with a diastolic BP of more than 90, pre-existing renal disease, diabetes mellitus, and also in patients with APLA. APLA, we should also include low molecular weight heparin, or there is a abnormal artery Doppler before 20 weeks of gestation. All these patients, low dose aspirin is useful in preventing preeclampsia. So here we can see that in chronic kidney disease also, we should add low dose aspirin to prevent preeclampsia. So coming to the progression of CKD, there is compensatory intrarenal vasodilatation in already the patient has damaged nephrons. Because of the increased renal plasma flow, the remaining normal nephrons will try to compensate for the work that is to be done. So there is compensatory intrarenal vasodilatation, hypertrophy of the servo. So this will further damage the nephrons and this will further worsen the renal function, resulting in progression of the CKD. So this graph, we can see that normal pregnancy, there is volume expansion to around 50%. In eclampsia, it is only 25 to 30% in that range. In mild to moderate chronic renal insufficiency, it further increases even more. In severe, it increases further because only till 20 to 25. Even with this, the kidney is not able to compensate. It further worsens the chronic kidney disease. So here also we can see that the patient with creatinine values more than 3 may permanently lose kidney function with pregnancy. For example, if the patient is supposed to require dialysis after 5 years, during pregnancy, she may require dialysis in the during the pregnancy itself. So dialysis in pregnancy, if the person is previously on dialysis, it has to be continued. There is a worsening of kidney function during pregnancy. Initiation of dialysis can also be done. So venous thromboembolism in nephrotic range proteinuria, patient may have thromboembolism. So that patient low molecular weight heparin has to be used. So anemia in pregnancy is because of the iron, most commonly iron deficiency anemia. In CKD, erythropoietin will be less. So in that patient, we should use twice the normal dose of erythropoietin. Volume overload, we should maintain euvolemia in this patient. So follow-up in CKD, the urine analysis we should do 4 to 6 weeks to look for proteinuria, pyuria, and hematuria. Pyelonephritis or UTI may worsen further urinary tract further CKD, chronic kidney disease. So urine analysis has to be done 4 to 6 weeks. As per the blood pressure, target is less than 140/80, but it should not be less than 110/70 because hypertension may decrease blood flow to the fetus, causing IEGR. Renal function has to be monitored every monthly. In the stage 3, 4, 5 patients, it has to be done twice weekly. Hemoglobin, iron supplements, and erythropoietin should be used. USG to rule out if there is any obstruction, if at all needed, not in all patients. So when to deliver in CKD for stage 1 and 2, delivery more than 37 weeks should be achieved. Stage 3, 34 to 36 weeks. Stage 4, 5, 32 to 34. So drugs in pregnancy, AC and ARB inhibitor should be avoided because it will cause renal agencies in.
Brightlin, I think we'll just go to the your take-home slides because I think we're running out of time.
So summary, creatinine value in pregnancy can be misleading because there will be a fall in creatinine value. So always do a UP by UC ratio or 24-hour urine protein, and also avoid nephrotoxic drugs and watch out for preeclampsia and CKD progression. You should differentiate between the two and to identify preeclampsia and further treat promptly. World Kidney Day is celebrated in March 9. It was done in last week. So,
thank you, Brightlin. Any comments or questions from the audience?
30 weeks lady, 30 weeks of gestation lady coming for the first time was not diagnosed with CKD. Was coming for first time, having high BP and 24 urine protein also showing proteinuria more than 300 milligrams. So in that case, shall we take creatinine as a marker to differentiate whether the patient is having CKD or preeclampsia? Because in preeclampsia, what we are saying, creatinine level is going down. In CKD, creatinine levels will be up. So shall we take creatinine as a marker to differentiate between these two? Or
no, in this condition, we won't be able to differentiate between this preeclampsia and CKD because we don't have a baseline creatinine value. So between these two, because both will have proteinuria as well as this elevated creatinine, because preeclampsia will present in AK if it's severe. So treatment will be almost the same for the both control of the blood pressure and proteinuria. So what we have to do is monitor the creatinine and proteinuria in 1 to 2 weekly duration to see if there is any progression of CKD. So for preeclampsia, we can also check for HELLP syndrome. With this, we'll be able to differentiate, but we won't be able to perfectly differentiate between that. There is only preeclampsia, there is only CKD. There could be both parts together. So only these alone we have to look for it. Treatment stays the same for the both.
No, I think that's different. Basically, when you say preeclampsia, the treatment is delivery. This is CKD, you can dialyze, maintain, and hopefully push them to delivery. You said proteinuria 300 at which week? Sorry,
30 weeks.
30 weeks gestation.
Proteinuria and hypertension.
Okay, so if you have hypertension and new onset proteinuria, if you are seeing proteinuria all through its different from a new onset proteinuria. Now there is, I think Ruth is around. Ruth is just sending out a paper on proteinuria in pregnancy. There's a concept called isolated proteinuria, which is basically more without the hypertension. If you have with hypertension, then you classify it as preeclampsia post 24 weeks. And the treatment is delivery if you can't control, especially if the blood pressure is going up or the new onset proteinuria which is going up, platelets falling, uric acid going up, your enzymes going up. Any of those things will kind of want to do a delivery because that is the treatment. CKD by itself won't present at 30 weeks. You'd expect to see some sort of a baseline. Just even a UP by even a lipstick, because that's what they do every time that they book a patient. They will do a lipstick And if the dipstick is more than 2 plus, then it indicates a 300 gram, 300 mg proteinuria. Proteinuric CKD or proteinuric renal disease has a poorer prognosis compared to a CKD in pregnancy because they tend to go into preeclampsia quicker and faster. When we did Ruth's study, we looked at proteinuria, which is not related to gestational hypertension disorders, and we found it as 8 gram. That's where the AURLC kind of had a cutoff. You tend to have a poorer maternal and fetal, especially fetal loss. So that's probably your. So proteinuric disease is different from a CKD by itself. Here, this patient is somebody who had metabolic disease, diabetes, hypertension, diabetic retinopathy, renal failure, all of which related to the metabolic disease rather than a proteinuric illness per se, not just a renal disease. So what we may have to do for her is if she does worsen, we may have to kind of support her with dialysis. And we have had some patients who were in CKD who required a couple of dialysis during the second trimester, and then we were able to them. Usually set a time to say by 28 weeks, by 36 weeks we manage. So we do MPTs for these patients along with nephro, OG, anesthesia, and we take a very conscious call as to when we are going to how frequently will we assess, what are we watching out for, and what would be our triggers to say deliver or start dialysis. So that's what we do in these conditions. And I think MDT is essential because it shouldn't be a isolated condition.
So, and one more thing, to differentiate AKI versus preeclampsia, there is one test called PLG of split ratio. It's not available, but in Australia, they use that as a